This morning will take us through continuity in the medical home, as well as some details on the Central Patient Attachment Registry. And I want to welcome our speakers this morning. Our speakers are Dr. Darrell LeBuick, who is the president of the Section of General Practice with the Alberta Medical Association, Dr. Tobias Gelber, who is a physician in Pincher Creek, Alberta, also involved in the AMA, but specifically is sitting on the technical working group for the Central Patient Attachment Registry project. Dr. Heidi Fell from Calgary, who is also the chair of the Informatics Coordinating Committee for the Alberta Medical Association. Welcome, everyone. It's Barbara here, and we're going to get started this morning. I do want to point out that there are some features of the WebEx, so participants are muted, but we will open up the phone line for audio questions at the end. In the meantime, there's two features of WebEx that you can use. One is the chat feature, and the other is the Q&A feature. So please feel free to put your questions in as they arise, but we'll get to them later in the webinar. So here we go this morning, and I'm going to pass the floor over to Dr. Gelber.
So we have been on this journey towards the patient's medical home for several years now in this province. And we've been slowly chipping away at the various pillars, or I would say actually building the various pillars of the patient's medical home. Many of you on the call, if you're not familiar already with the idea of the patient's medical home, this slide up in the top right corner shows a picture of the document that's put out by the College of Family Physicians that outlines the various components of the patient's medical home. And so we have today we're going to be focusing on the sixth pillar of the patient's medical home, which is continuity. The pillar builds very nicely on the work that's done over the last year and a half in terms of panels. And so once we have all patients, which is a defined list of patients who would consider their family doctor to be a certain individual to be their family doctor, and that family doctor also agrees. We now will focus on continuity as a concept, where those patients then get in and see the same provider over and over. So as you can see from this slide, there are a number of different recommendations that the patient's that there is for the patient's medical home when it comes to continuity. 6.1, care for each person in a patient's medical home should be provided continuously over time. And so basically that just means that as patients' care needs arise, they then see the same person or people in the medical home over the same period of time, thus building relationship. 6.2, patient's medical home should foster continuity of relationships between patients and each of their caregivers. So that's the same as what I just said. 6.3, patient's medical home teams should ensure continuity of care being provided for the patients in different settings, in family practice, office, hospitals, long-term care, and other community-based institutions in the patient's residence. Basically, what that's saying is that patients will definitely do better if the same person or group of people are able to provide care across a number of different settings. Where possible, being able to monitor people and care for them in their acute care settings, long-term care settings, etc., is going to provide a significant benefit. And see shortly that we actually have some pretty good evidence to support that. 6.4, patient's medical home should advocate on behalf of its patients to help ensure continuity of their care throughout the healthcare system. Again, you'll see the benefits of that shortly. 6.5, a patient's medical home should serve as the hub that ensures coordination and continuity of the information related to all the medical care services their patients receive through the medical community. And what we're referring there is informational continuity, which means that any that the patient is within the healthcare system, ultimately that information should come back to a central place so that all the information about that patient is in one location. Slide, please. So there is the relationship somewhat between panel of continuity. This diagram is Alberta's guide for family practices who want to implement the patient's medical home. I've told you briefly what the panel is, what the definition of a panel is. So continuity occurs when care is provided by a patient's own physician or team whenever possible. So we'll be doing this. When clinics know precisely whose care they're responsible for, they can provide care proactively versus reactively, meaning outreach stuff. Guess what you do for your various chronic disease management or population-based screenings, as opposed to waiting for something bad to happen and then identifying the disease. In addition, when you know who your panel is, you also know characteristics about them, and you can design the care team based on the panel's needs. So if you're to be in a population that's very prevalent with diabetes, then maybe having somebody on the team who has a special interest in diabetes or special skills for managing it would be beneficial. If you live in, or if you're managing a panel with low socioeconomic status and a lot of difficulties in social situations, then maybe social work or that sort of thing would be helpful. But the care team to support your panel is essential for optimizing outcomes. So we assign all patients to a provider panel and confirm assignments with providers and patients. This is the panel work that you guys have been familiar with. If not, there are lots of resources for you to become familiar with paneling. Once you know who those patients are, you would then choose to book those patients with their own provider or team whenever possible. So when they come in, having them come in and making access for them to come in so that they don't go to Merge or other primary care delivery services. And then when they do come in, having a system within there so that they do see the same physician over and over. Many clinics already do this, and you'll see some numbers which support that shortly. In order to maintain continuity as best as possible, using this panel information to proactively manage preventative care, calling groups of patients that are yours for chronic disease management, medication changes, and that sort of stuff, and using registries of patients to be able to manage them proactively and optimize outcomes. Please. And its benefits. There's been lots and lots of studies done, lots of out there in the literature. So we'll move on to the next slide, please, 7. Here is a slide which on relational continuity. And so relational continuity is that longitudinal relationship that a patient has with the provider and care team. And what they do is they look at when patients have good continuity versus not good continuity. We'll get to a definition of that in a little bit. They see that there is a significant benefit in a whole variety of different realms in the healthcare system. So looking at this slide, we can see that 8 out of 10 studies show that with good relational continuity, preventative care improves. Utilization is significantly reduced. Mortality, 11 out of 11 studies show that mortality is reduced with good continuity, that health outcomes are improved, cost savings in 16 out of 17 other studies, quality of care, patient satisfaction, and adherence to our recommendations all improve with relational continuity. This study, or this slide here, was created after a lot of different work. And so if you want to see those studies, there are references available on the website. Slide, please. So this here shows that as continuity increases, utilization decreases. So this is digging down a little bit deeper compared to that first slide. And here is actually Alberta data, if I'm not mistaken. And so what this shows is the different bars show different amounts of continuity. So the teal-colored bar shows that attachment is less than 50%. The turquoise one, 50 to 75%, and the pink bar is greater than 75%. So what that means is for the primary care visits that a patient had in the pink bar, over 3/4 of their visits is to our primary care provider or team. Conversely, less than half of the visits are to the primary care provider or team in the colored bar. So what we can see then is that for hospitalizations, there is a 6-fold reduction in hospitalizations if patients do nothing more than their own primary care provider. Additionally, for length of stays are about 10 times shorter, those that are attached, and the cost to the system for these patients is about 8 to 10 times lower for patients attached. And so I just got confirmation that this is indeed Alberta data, and that shows the power of continuity in relation to these sort of things. Next slide, please. Is diving down further. So the far right-hand graph on the last one was about cost, and so now we're breaking down cost even further and showing how cost changes in respect to how sick a patient is. So what this uses is something called clinical risk groupers. This is a very expensive piece of software that Alberta Health Services has that essentially divides patients up into 1,100 different categories. These categories are then coalesced into 9 major categories, and you can see that up in the top right-hand corner. And we look at the impact of continuity on these categories in terms as it relates to cost. So on the hand call axis is cost, and on the right-hand axis is continuity. What we can see that for all of those categories of patients, regardless of how sick you are, as continuity improves, so the graph going to the right, costs go down. What's interesting, though, is that the sicker the patient is, so the pink one, for example, those are chronic disease, 3 or more organ systems. Those are often the frail elderly, the multiply comorbid patients. We can see there that those folks have significant cost savings, or the most significant cost savings, because A, costs the system most, but also have the most significant drop in the costs when they are attached to patients. Again, we're attached to the providers. So this is Alberta data, and so it's fairly powerful, showing that as that will do significant savings to the system just by having continuity and allowing our patients get in to see us. Next slide. If cost is not enough of a motivating factor for folks to want to do this, this slide should be, in my opinion. So this also is Alberta data, and essentially what this shows is that as continuity goes up, so as the graph moves to the right, the chance of your patient dying, or the mortality rates for that population, drop significantly. So if people are essentially unattached, so that's the left-hand bar of less than 30% of their visits are to their primary care team, their rate of mortality per 100,000 is well over 1,000, as opposed to those that basically see their own primary care physician most of the time in the far right-hand column. 90 to 100% of their visits are to their primary care doc. They're below 600 deaths per 100,000 population. So by being attached, things typically must be getting picked up sooner, interventions happen earlier, and the chance of dying goes down. They'll do eventually die, but the chance of dying earlier would be less if you're attached to a physician. Okay, next slide. So it's that we now have really good evidence in Alberta that continuity of care is essential in primary care in order to provide optimal outcomes. We have we know it's good cost savings. We know that it's good for patient outcomes. We know that it's good for the providers. And so, in general, this is what we're striving for as the next step. It's a logical step. We've already spent as much time as we have on panel, and so moving now towards making sure that those patients are seeing the same person or people over time is going to help further drive the improvements that we're already seeing in Alberta. So I'll stop.
Thanks, Amber. And Dr. Buick, let's take us through the introduction to the Central Patient Attachment Registry.
Okay, thanks, Barb. So thanks again, everybody, for joining us this morning here. It looks like there's about close to 50 people on, so thank you for taking the time to hear about the Attachment Registry and continuity. So I'm going to go through a few slides here that just reflect where things are at and what the Attachment Registry is. If we go to slide 13, the SGP bulletin that we sent out back in the fall of this year basically defined where things were at that time, and just to review what we talked about there was similar to what Tobias has just mentioned, the advantage of continuity in this process of healthcare improvement, where the continuity offers value, and the Attachment Registry acting as a key technical enabler in order for this to happen. We also talked about some of the timelines in this bulletin, and we're now looking into the spring here where we're anticipating some limited production rollouts over the next little while. Next slide. What is the Central Patient Attachment Registry? These slides, a number of you may have seen in the past, and there's been no significant changes to these. The Attachment Registry was established in the amending agreement between us and Alberta Health back in 2016. The section of general practice is working on this joint initiative with AH and AHS, and Tobias is on the working committee for that and has been doing a lot of work in the technical areas of getting this going. We're looking forward to having this as a common provincial database where we have a registry of primary providers and confirming their panels. So this is more an ongoing process with paneling more so than a new process that's going on. The most important thing is that this is the key technical enabler for improved continuity of care. This is the linchpin. If we are not successful in obtaining and having a successful attachment registry, then our ability to move forward with any component of continuity are significantly compromised. So this slide has shown up at PCN leads as well as other various presentations, and it just talks about our panel progress over this past while. And we have seen a general improvement in our paneling, where in 2017 we have close to 70% of physicians that are either established or very actively working on a paneling process. We still have a good number that are in the gray area of the unknown, and we have the not interested area at about 12%, which is still a bit of a concern, but it's the steady rain that soaks, and we're going to keep on working on paneling as best possible. Slide 16 is another area of representation of where we're at with our panel progress. So as I talked about, with our panels progressing the way they are, this attachment registry is the next step into making this a more organized process than what we've had in the past. Next slide is continuity, aim, and improvement in system-wide continuity. So this scatter plot here shows us that over the past 3 to 5 years, we see as the degree of attachment has been increasing, it has been increasing in different numbers of PCNs, PCNs with 50,000 or more patients, PCNs with less than 50,000 patients. So we've had a general increase in the amount of attachment that's been going on. So 80% is set as a goal for continuity because it is the tipping point for significant benefits with respect to continuity. And we go back to the slides that Tobias presented where it can help with utilization costs as well as mortality. So this is the goal of quality improvement in our healthcare system.
We're going to move along to dive deeper into the discussion of informational continuity with Dr. Heidi Fell.
The next slide, please. So in our current state, the stuff that's in your EMR is in your EMR, and the stuff that's in Netcare is in Netcare. And they're, unless you do print and scan, they're not often connected. So one of the things in the future state is that these two things will be much more closely linked. Slide, please. So for this slide, this shows the one ideal representation of the future, which shows that there's lots of different pieces. So just like your medical home is the hub for the patient, there will be a hub for information within Alberta. And your EMR will connect to it, NetCare will connect to it, the personal health portal will connect to it, hopefully SIPS data, analytics, and also a central patient attachment registry will form a part of that. And so there will be bi-directional communication between all of these things as a vision. So that eventually, once you're attached to a patient in CPAR, everybody will be able to see that information. And also, what we're working on is trying to that you will get notifications about significant things that happen to your patient and eventually documentation about that as well. Yes, please, Barb. We do note that this is the key technical enabler to continuity. So while all of this is developing, there are lots of other things that you can do to look at continuity and that are drivers for continuity. So PAN ID and CPAR is the purple stripe in the top right, but there are lots of other pieces. So public and patient awareness, which we're working on AH to get done, physician remuneration, regulations and policy, management, analytics, integration, clinical decision supports, the funding model, et cetera, access. And so, while we're waiting for some of these key things to come along, and CPAR is coming along fairly quickly, hopefully, but there are other things that we can do. For example, if you're working in a large clinic, you can increase continuity by changing to working in pods so that if you're not available, you have a fairly small group of people that would be available that would develop their relationship with the team over time. And so, for example, for docs like me that only work part of continuity of 80% to myself is going to be a challenge, but a continuity of 80% to my team or my pod, or in my case, my clinic's small enough, my whole clinic can be a pod, will help achieve the same benefits without them actually seeing me 80% of the time. Thanks, Barb.
Thanks, Dr. Fell. I'm going to bring you through some details on how the Central Patient Attachment Registry will work. As myself, and I sit on the technical working group with Dr. Albert and my colleague Chris Diamond and Arvel Ballenline as well from the Alberta Medical Association. So to the registry is, first of all, understanding panel and practice readiness to participate in the registry. So we're looking at 4 key behaviors that should be in place from graphic of those practices with well-established panels. So it's confirming attachment to providers at check-in, recording that in the EMR, which provides a date stamp, and we're going to state the importance of that date stamp. Maintain and review that list, and that would involve panel maintenance processes, and using that list proactively to deliver care in the form of screening care, chronic disease management, or care planning. So the key steps there are that in the practices, paneled patients are distinguished from what we'll call caseload patients. And while not every practice does, most practices offer services or episodic care that would allow the formation of caseloads. And some of the examples here are maternity care, sports medicine clinic, aesthetic services. Those are the type of groups of patients that form caseloads. They're not on a provider's panel and would not be uploaded to CPAR. So key to understanding is that paneled patients are uploaded to the registry. The Central Patient Attachment Registry process will look like. At the top, clinics are confirming the panel, so they're already doing this. There will be a registration process for somebody that we're going to call a panel administrator that will administer the panel for a primary provider. It's actual registration of the providers in that process as well. Then those panel lists will be uploaded to the registry by panel and attached to the provider and the registry. The registry is going to look for duplicates and mismatches between all those that are participating and uploading. The panel administrator will receive reports, we call a panel conflict report and a mismatch report, and they're going to use those reports in the clinic to resolve those conflicts, and it's a really good fit with panel management work. Any deceased patients are removed from the panel. The clinic would have what we'll call a validated panel list. This is going to be a quarterly process through which it will happen. Now, around this, there will be supports available to primary care networks and teams within the primary care networks. So some of them are labeled here. We have the STEP documents, which are supportive documents for panel readiness. We have a readiness checklist, and we have EMR guides and more EMR details that are coming. Detailed provisions of how to prepare those lists and get them out of the EMR and saving them are going to support the use of the registry. There's also support for the whole registration process. Person we're going to call the access administration, which is probably likely the person that is the NetCare access administrator in the clinic right now, as well as the panel administrator. And then there will be a guide for the registry and how to use the technical application as well. A PCN provider and team toolkit will support downloading the reports, sorting those reports, prioritizing who manage on those reports, a script, and approaches that practices may take to using that information in their practice and incorporating it with existing panel management processes. Finally, if panel size is identified as something that the providing team needs to work on, there's some tips and guidance on where to start that work as well. So reports for the Central Patient Attachment Registry. The goal as well that we're going to use is that and the programs that we're working with will provide support to PCNs and resources such as improvement facilitators to work with the practices. There are trained improvement facilitators that want to avail themselves of the results of the tools directly. They may do so. Two key tools that will be new and available to practices: the conflict report. So this lists any patient that the provider put into the registry that another primary provider said was on their panel. Importantly, it lists the date that the provider last saw the patient, the last visit date, and it lists the date that the patient was last confirmed. So it's really important that clinics are confirming patients at the practice. Really good recommended process measures for this is confirmation rate. It's a really good tool at the practice to determine really how often those patients are being confirmed at the practice, and very good supportive for improvements in that area. The second new report is the mismatch notification report. It will provide lists of a patient on the panel who's deceased, but also where the information doesn't match the patient-client registry at Alberta Health. So get ready. Some important tools that you can be using right now are the panel and CPAR readiness checklist, roles and responsibilities of a CPAR panel administrator. And again, continuing to confirm those patients at check-in. And those materials are available on the Toward Optimized Practice website. Tools, which I mentioned earlier, the supportive tools for every panel are available, and they really allow a team to dive in and look at their panel identification and their management processes as well, and look for opportunities for improvement. and most improvement facilitators in Alberta are trained on these tools. Registry and what's in it for these various groups. So, Daryl, I'm going to go to you. What's in it for the patients?
Thanks, Barb. So if we just go back to that slide that Tobias had gone over, I mean, whenever we go through changes and everything else, we always have to look at where is the value in all of this. And especially in this time in primary care where we're going through significant amounts of changes, one of the things that we want to focus back on is the potential value for the patient. And that's where we hopefully will get the biggest buy-in, is that there is obvious value to patient care and quality improvement here. And that slide once again reflects the fact that with the increased continuity, we see the chance of improving just general health in patients. There is more satisfaction. They've received their care. We hopefully enable them to take better care of themselves, and we have better health care outcomes. So that's what the biggest value to the system is for patient care.
Benefits to providers and PCNs.
Okay, so providers and PCNs, in my mind, the benefits are that we are currently working in a system where we have relatively limited resources. PCNs have been a huge boon. They have provided us with some great benefits, but there are many of us now that are kind of maxing out the dollar amount that we have been provided and could use more. This seems to be the case across the healthcare system. And so once we're in a system where we have limited resources, then most efficient use of those resources is going to be required. And so when we don't know who our patients are and we're not seeing them ourselves all the time, then we become less efficient. And we may be ordering tests or seeing patients that are not ours, using our PCN resources to manage patients that are not ours, and thereby limiting opportunities for the patients that are ours. And so by knowing our patients and seeing only our patients, I think we will make the best use of the limited resources that we currently have, both the resources that are ourselves as primary care providers, and also the resources that the PCNs provide in the form of extra staff and team. So really, I think that's where the biggest benefit for PCNs and for providers is that we make the best of the limited resources that we currently are operating with. So we don't have duplicity of care, and we don't have, these are a couple examples, reduced duplicity of care, so we don't have two different providers ordering the same mammogram, and we don't have two different providers both trying to do a complex care plan on the patients. So that's where I see the benefits for continuity currently.
Thanks. And Heidi, let's talk about informational continuity.
So to talk about the benefit currently, and some of the benefits I'm going to talk about are yet to come, but once the registry is populated and conflicts are managed, then the patient's record in NetCare is going to have the name of their primary provider and their practice contact information. And also we will work with ConnectCare to ensure that this information is available to docs working with NHS as well. So the clinic can be contacted in urgent situations. And we're actively working on, now these things always take longer than you hope, but we're actively working on a way to get notifications of emerge visits and hospital admissions and discharges to the CPAR connected provider. And then with that done, future state would be to actually deliver the reports to the provider identified in CPAR as well. So CPAR really is, as Daryl said, is the linchpin for the future, where primary care providers will always know where their panel of patients have had an important interaction with the healthcare system other than at your office. So again, some of these things will take time to develop, but CPAR is really the foundational step for any of these things, including for PCNs to be able to know who their panel is. So we're looking at CPAR as a foundational element of an informational pyramid, And as we build on top of it, we get more and more value to both the provider, the patient, and the PCN, but CPAR is the base. Now, having said that, next slide, please, Barb. Challenges. There are always challenges in a project like this, and this one is no exception. As you get closer and closer to being ready, I always liken it to peeling back the onion, and you think there's only one layer underneath, but surprise, there's 6 or 8 layers underneath that you didn't really encounter until you peeled back the first layer so that you could understand a little bit better. One of the challenges that PCNs face, of course, is that the resources that Tobias alluded to, also that not all of their physicians are interested in doing this work. And if you're already doing paneling work, the new piece of work is the upload piece, which eventually will occur automatically, eventually. But the upload piece will be new work initially, as well as reconciling the conflict reports. And don't worry, there'll be scripts and things provided to help physicians and their teams navigate through those conversations as well. But if you're not already doing paneling work and you don't buy into the medical home, this might not be the right fit for that clinic at this particular time, and it would be new work that they're not already doing. In addition, you know, these things always come up. There's challenges sort of finding workflows, and it always takes more work to understand workflows than people anticipate at the beginning. So we're currently working through some of those challenges, and hopeful that we'll find solutions for them relatively quickly. They're to be expected in a project like this, in my opinion. So I am happy that CPAR will continue because it is such a foundational element to everything that we're discussing.
I know you've been busy on the working group for the past year and more. Anything you want to add in the challenges department before we move on?
This is a technical solution, and it is co-managed by a number of different agencies. And so having all the agencies on the same line is a challenge. And any kind of massive undertaking where we're trying to get 4 million patients worth of data and 4,000 or 5,000 physicians worth of data and matching that up is a challenge. It's, you know, we're heading towards a limited production rollout where we're going to be starting to work through that, but no doubt there will be some glitches along the way. We ask that anybody who's part of that be patient and help us with constructive feedback to be able to rectify the problems. As you can see, the underlying reason for this is got a lot of strength and evidence behind it, but to actually implement it is going to be challenging, and we just ask for people's patience and feedback to help us with coming up with a solution that's going to work for most people.
Thanks, Tobias. And I just have a couple more slides and we'll get to the Q&A. So a couple key points we want to mention this morning about getting ready as a PCN. So right now, we really are in the readiness phase. Ensure that your members are aware of the Central Patient Attachment Registry, what it is, what it's not, and really enforce that ability that the registry will be that future enabler for continuity of care, in addition to many of those other actions that can be taken at the practice, and of how to get ready. We have some tools that are available and some that are coming out with the limited production rollout. So those are also supportive of this at the practice and PCN level. In terms of lines, we're in the awareness and readiness phase. Approach some groups to partake in the limited production rollout that's going to begin April 1st. So Dr. mentioned there are going to be numerous ways that information can be uploaded to the registry. First, an automated way will be any practice that chooses to enroll in the Community Information Integration Project. Their panels will be uploaded automatically. And MicroQuest HealthQuest has also developed a stock report out of EMRs that will enable easy production and matching and upload to the registry. So in April, we're going to begin with a limited production rollout, very small to validate the whole set of tools and processes that are ready for the registry. And following that, there will be additional waves of the limited production rollout, followed by general rollout once we have validated and evaluated everything to ensure that we are ready for broad rollout. As mentioned, some of those tools available on the Toward Optimized Practice website, and you can download them along with a very extensive Q&A. So I think we have a number of questions in the Q&A. We'll start with the first question, and the first question is, what will be in net care if the patient is paneled to 2 or more physicians? Will it show nothing or show them all? And, while that is a future functionality of net care, we have and the registry, because we have to get the registry being used first, anticipated that it will only flow to net care if a patient is attached to a single provider. Reason being is we've already discussed the use of the registry by others, let's say an ER department, and saw, let's say, 5 providers, wouldn't know who to contact. So it is when a patient's attached to a single provider, it will flow net care. So the next question I'm going to actually to you, Tobias. The question is, will the physician be interested in removing patients from their panel if they get informed that the patient is paneled with more than one physician? Well, they will lose a patient they could bill for. Tobias, you might mute.
Okay. Sorry. Can you use it again?
What's the incentive for a physician to remove a patient from their panel if they're informed that it's paneled with more than one physician? Will they lose a patient they could bill for?
So from a financial standpoint, I think all of us are under the same pressures in that there's not enough hours in the day. So while there may be the perception that that is dollars moving out of your office, there will always be paneled patients that need to be seen. In the unusual circumstance where you actually are under-paneled, then there are, of course, processes in place and well established to be able to constructively build your panel with patients that will continue to come back and see you, as opposed to those that are just using you as a backup and really have another family doctor elsewhere. So really from a financial standpoint, your day will always be filled, even if you are trimming down patients and only focusing on your own patients.
Thank bias.
Well, if I can just add to that.
Thank you.
I think that, when it comes to this type of thing, I think it's an opportunity, first of all, to have a conversation with the patient around them really finding out why they are seeing 2 different physicians at the same time and what the purposes are around it, and make them aware of the importance of continuity. We need to start to communicate and inform our patients of the value of staying with one physician versus roaming around to episodic care centers or other physicians for that matter. Is there any financial incentives yet in the system for us to maintain continuity? No, there isn't. However, for comprehensive primary care physicians, and we all know how income is challenged when we practice in these styles, we do hope into the future that it can be more financially rewarding for us to practice comprehensive, continuous primary care versus episodic care in that manner.
Thanks for that. Question in the Q&A is about what is really considered to be a confirmed patient. And I'll see who wants to take this question of those of you that are confirming patients at your practice. What really does that mean in your practice to confirm patient?
bias. In our practice, the way that it works is when a patient comes in, the reception has a script where they go through their demographics. This is still your address, still your phone number, and then they just tack on to who would you consider to be your regular family doctor, and that is there's a box on our EMR where they tick that, saying that the verification has been confirmed. So that's the way that we do it in our practice. Now, that does rely on the patient being honest and open, and it's very clear to us that there are some patients that probably do that, have the exact same confirmation at another clinic, because we have patients that are registered with other clinics as well. And so for us, and that triggers a conversation with the patient when we are made aware that they are on somebody else's panel. And so then we can have a non-confrontational discussion with them about the circumstances around them being registered with another physician. Invariably, what we've found is that maybe the other physician has not had the same robustness of confirmation of patients and are just putting them on their panel without a clear paneling process, and so it becomes clear to us eventually, one way or another, that they either are or are not our patients.
Thanks. Do you want to add to that, Heidi or Daryl?
We're using a 3-year time frame, are we not? So they haven't been confirmed within the last 3 years. They're not to be on your panel.
That's the definition of an active panel, is having that confirmation within 3 years. And that's where some clinics are, if the patient's had 0 visits in 3 years, usually make that outreach call, usually also to offer proactive care if the patient's due for something, and confirm that they're still a member of the practice and intend to see that primary provider. Questions in here, and Heidi, I'll field this one to you. You mentioned the pod. I don't know if there's data on the sub-pod.
Oh, yeah, that is a good one. I know, so I looked at the literature myself on this one, but I know that the University of Calgary has done some work around this, and I believe they chose a pod size of about 3 full-time equivalent physicians. So and an assumption that they did that based on some data, but that's as far as I can go on that one.
Okay.
Our pods are 2 physicians, and that's just due to the amount of work that those physicians. It's 2 to 3 physicians in ours. And so that's just due to the amount of work that the supporting staff are able to do that is generated by those physicians. So our pod consists of a receptionist, an LPN who is our panel manager and does the outreach work, and a medical office assistant who does the day-to-day routine stuff in the office. And then those 3 then support anywhere from 2 to 3 physicians.
On the next question, I said the phrase, if you have a panel size you need to work on. And what does that mean is if you're over-paneled. If you have too many patients in your panel and the supply and demand equation does not match up, that'd be an opportunity to work on enhancing access at the practice or making the supply and demand match up. Really, we have some tools, hand tools that we're going to provide. And then if a clinic really needs to work on that, the greatest opportunity is to work with Access Improvement Measures Program and to get that supply and demand worked out. Heidi, the next question to you. And does the notification activity only apply to an AHS visit? So we're talking future functionality, but what is the vision with respect to that?
Initially is that it would be emerge and hospital-based visits. There's a lot of work we would need to do if you wanted to, for example, if you had to be able to choose what things you were notified of your patients, because we're going to be notified of everything, because that might overflow our inboxes. But the difference between sending emerge visits and inpatient activity to all docs versus allowing docs to choose which things they want to be notified of is a significantly different level of technical challenge. So that would be something that we would be looking at sort of down the road, but initially I'm anticipating it would just be AHS emergency visits and inpatient opportunities, HS including covenant, so including gray meds and misericordia and things like that.
Okay, thank you. The next is a comment, but I'll see if any of our physician leaders want to respond to it. Currently, there's an abundance of physicians in Calgary and not enough patients. Many docs are trying to build their panels, which is more and more difficult. Any response to that in relation to the registry?
I don't really have a great answer for that situation, but I think this is the opportunity where as we get challenged in some of our physician resource planning at the provincial level, obtaining and showing evidence of your panel as a reinforcement of how you're managing your practice and how you're building your practice. But no doubt it's going to be higher conflict within the urban areas as to whose panel is whose in compared to more balanced or under-resourced areas. And that will no doubt be a challenge to the future.
So what our clinic has recently encountered is trying to replace a couple of physicians, one who moved out of the country and one who's retiring from family practice. And having a confirmed panel, you know, granted CPAR doesn't exist, but this physician did have a confirmed panel, was a huge benefit in attracting somebody to replace them. So having an established panel on CPAR is helpful in that respect.
The other thing that has been talked about at very small levels is, you know, with the established panels in urban areas, the question of actually having a monetary value to a panel as physicians are coming in and taking over practices in comparison to yesteryear where all you did to do was hang a shingle somewhere and you could set up a practice.
Thank you. Next question is there a provincial plan for educating the patient of this process and its benefits? This work is underway, as it is a partner with Alberta Health and Alberta Health Services. There has been identified early in the project that this was an important aspect. Partners are planning this, and the work is just forming and getting underway. So there is a plan that there will be both patient education and citizen education about continuity of care. Is this
Barb, I just want to add to that, and just to make it clear to the person who asked the question, this was a very initial comment that we had to government when we started this whole process, that it was imperative that we have a shared ability to communicate this to the public and to be perfectly honest, we have experienced some challenges and some pushback from government as to their level of willingness to participate in this process, but we are still working on the importance of them actively participating this in some way. In fact, we're hoping that will continue that way, because I certainly don't want to see this act as a barrier to moving forward with this into the future.
Thank you. Next question. This is labor-intensive work. Will there be more funding to get it rolling? And I will roll this into another question that somebody else submitted, is they haven't invested in formal panel managers. So what about the work to get this done? Who would like to field that?
I can take an initial stab at it. So is there funding for this? I would say that right now the answer is no. That's the quick answer. But this work that we want to support in primary care, I would say 100% it is. And when I was on the Section of General Practice exec, and I'm still part of the Section of General Practice Compensation Working Group, we're having significant discussions about how best to support this. And there's really two main thrusts that we're looking at. One is through the blended capitation model, because you can imagine that the blended capitation model, where you're getting paid for care of a patient as opposed to episodic visits, would align very nicely with this work. And the second is through some changes to schedule of medical benefits for fee service that would incent continuity. So it'd be things like potentially adding in some after-hours modifiers or continuity riders or things like that that may be able to incent this kind of care. We've been asking government for this for quite a while. Their payment system is archaic, and they say that this is going to take an incredible amount of money and work in order to make this happen. So it's on the radar, but it is not happening right away. Daryl, Dad?
I think the other factor in this, too, is that if the government wants this to succeed, they have to recognize that time to put into this also requires money. And I think we need to communicate or have some good relationships with our primary care networks who have already been helping our clinics or should be helping us with paneling, and utilizing the resources that they have to continue this process, because there's value to our clinics, there's value to our patients, and there's values to our PCNs in having these panels organized to a high level of functioning.
Working really hard to make the workflow as simple as possible. So, that's one of the challenges that we're encountering, is that workflow is a little more difficult than we'd initially anticipated. So we're working really hard to find answers to that, to make it as simple as possible for all clinics to participate.
It's 9, and we've had a great discussion this morning. And before people get started with their day, I wanted to sincerely thank Dr. LeBuick, Dr. Geller, and Dr. Fell for your participating this morning and sharing your knowledge and experience of this project as we get ready to move forward. So thank you. We didn't get quite through the Q&A, so we will be asking questions that have not already been answered to our frequently asked questions document, which is posted on the CPAR tab on the Toward Optimized Practice website. You may find that some of those questions are already answered in those frequently asked questions. So thank you again to everyone for participating, as well as our speakers, and wish you a good day.
Thanks.
Thank you.